So welcome everyone to the Washington State Telehealth Collaborative. John Scott here at the University of Washington. We are going to start off with just roll call here. Maybe if we can start with folks in the room. Francis, you want to kick us off?
Oh, hi, good afternoon. This is Francis Goff from Molina.
Nicole Brown with UW Medicine.
John Scott, UW Medicine.
Representative Joe Schmick.
Stephanie Shushan, Community Health Plan of Washington.
Great, and then let's go to folks on the line here. I see Dr. Jeff Jones. Jeff, good to see you.
Oh, Jeff Jones, family physician, Newport, Washington, assistant clinical dean for the UW School of Medicine.
Great, glad you could join us, Jeff, and thanks again for hosting us last time. I see Cheryl Buchala who's on the line. Cheryl, you want to say hi?
Hi, Cheryl Buchala from Primera Blue Cross.
Great, thanks for joining. Danny Lorden from Providence, you want to say hi?
Good afternoon, Danny Lorden, Providence St. Joseph Telehealth.
Great. Welcome, Danny. Dr. Frank, do you want to say hi?
Hi there, Josh Frank, American College of Emergency Physicians, Confluence Health.
Great, thanks for joining. We also have Joelle Fathi who just joined us. Welcome,
Hi, good morning, afternoon.
I see, let's see here. Let's go to Brody DeChinko. Brody, hi.
Hi, literally just signed on. Hello.
So Brody is representing Regents and Cambia Grove. And I see Ray Hanley from LNI. Ray, do you want to say hi?
Ray's here.
Great. Welcome, Ray. I see Lori Wakashige. Lori, you want to say hi?
Hi, everyone. This is Lori Wakashige from Legacy Health.
Thanks for joining, Lori. Mark Lowe from Seattle Children's.
Hi, everybody. It's Mark.
Welcome, Mark. Chris Gable from Kaiser Permanente.
Yep. Hi, this is Chris. Good morning, everyone, or good afternoon.
Afternoon. And then I see a couple of phone numbers. So if you are a member of the collaborative and you haven't said hi yet, if you can please introduce yourself.
Hi, this is Patrick O'Brien from UW Medicine.
Did you catch that?
No. Could you say that one more time?
Say that one more time. I think we had two people.
This is Patrick O'Brien, UW Medicine Telehealth Services.
Okay. Hey, Patrick.
Hi, Patrick.
Hi.
Hi, and Adam Romney from Davis Wright remains here as well.
Great. Glad you can join, Adam.
Hi, Steph Cowan with Multicare.
Great. Yeah, Stephanie, I was about to call on you. So glad you could join.
This is
That's Riccelli. I recognize.
Yeah, Representative Riccelli. You kind of got cut off there. Can we just do a quick sound check? Because I know you want to be able to speak during this meeting.
Yeah, this is Representative Riccelli.
Okay, great. Glad you could join. I know Senator Becker had a family emergency, so won't be able to join us. But Senator Cleveland, are you able to join? Chad Gavilan from Virginia Mason. Kathleen Damon from Swedish. And I know Cara Tal is going to join us shortly. She's probably on her way. We have Stafford Strong on the Representative Caucus. And anyone else want to say hi?
Scott Kennedy.
Hi, this is.
We have Scott Kennedy. Go ahead.
Yes. Good afternoon.
Great. Anyone else on the collaborative wants to say hi? We will be able to, during the public comment, we can have people introduce themselves. If you're a member of the collaborative, we want to take attendance now.
This is Amelia Davis. I'm filling in for Marissa Ingalls for coordinated care.
Okay, great. Thank you. Great. Well, good. All right, anyone else from the collaborative official membership that wants to say hi? I think we got everyone.
I think there's a couple people in the room.
Yeah, we'll do the public. We will have a time for a public comment towards the end of the meeting. So I think what we'll do next is I'm just going to share the agenda so everyone can see what we're going to be doing. So be reviewing the minutes in a little bit. So if you online, you want to pull those up from the announcement that Nicole sent out. We'll be reviewing those shortly. And then Stafford will give us an update on the two bills that are being considered in the next session. We'll hear from Elliot Weiss about the nursing compact and also hear from Representative Riccelli at that time. And then we have a talk from Ryan Sterling about virtual urgent care and the cost effectiveness. And then Carl will give us an update on the NRTRC. We have a couple other grab bag items there. So let's go next to the minutes. If folks want to just ask you to pull those up.
That's number 2.
I'm going to pull those up for folks who maybe don't have them handy.
And for folks in the room, feel free to move the name tags as needed. You never know who's going to come in person. Oh,
Right there.
here. And then hit share. There you go.
Okay, sorry, I'm using a PC. I'm used to my Mac. So for those of you who weren't able to join us in person, last time we were hosted by Jeff Jones in Newport. We even got to see a parade afterwards, which was really exciting. And so I want to say thanks again for Jeff and his hosting the collaborative. What are the great things they're doing. We heard from a psychologist about some of the challenges that they're facing on the policy side of things. And I think we do have a letter that we're going to do. Is that right, Nicole?
Yes.
Okay. So we do have an action item. We'll follow up on that. And it was the majority of our conversation last time. We did talk about the nursing compact as well. And we'll be getting some follow-up today from Elliot and Representative Riccelli. And then starting to get into some of the subcommittee work, we'll have a little more time later on today to finish up that work. If there's any edits or comments on the minutes.
Motion to accept.
Yep, if I can get a motion to accept the minutes.
So moved.
In a second.
Second.
Okay, all in favor, please say aye.
Aye.
All in favor?
Hi.
Not in favor, please say no at this time. Okay, great. We will post those to the collaborative website. Thank you all for typing those up. So next thing I want to do is turn it over to Stafford Strong. Stafford, do you have any slides you want me to share, or you just want to talk about those two bills?
Yeah, just these two bills. I shared them with Nicole. I don't know if there's copies. I think they were sent out in the email.
They're on your
Okay.
They're both somewhat lengthy, but there are other parts of law that currently exist. Most of it's existing law with a little bit of amendments. The first one I'll talk about is 5389. This was dropped last session, and it's still an active bill, though she's going to drop a striker that has different dates in it. This is the bill that relates to school mental health and psychology visits through telemedicine for students who may be at risk to harm themselves or others as a result of mental health. This program would develop training that would train all school staff, including bus drivers, administrators, anybody who has to do with students, because they're in a unique position to be able to identify students and when things might be going wrong. And then students that are identified are then screened by a school nurse or school social worker. And if they are found to be at risk, then this program will provide 2 telemedicine visits. It'll provide one, and then if a second one is needed, they'll do that visit as well. And one thing that came up in discussing this bill is, well, that's just 2 visits. You can't solve problems with just 2 visits. But Senator Becker's answer is that's better than 0. And then so they'll get those 2 visits, and those visits will be during school hours in a school room provided by the school, so at the school, and they can see a psychologist from a different site. In the event that it is recommended they do a 3rd, fourth visits, and so on, more treatments needed. Part of this bill provides that a list will be produced of psychologists who can see these students to hope that treatment can be ongoing. As for payment, that's another question that comes up. The bill allows the psychologists or those treating the students to reimburse them from their insurance, and for those students that don't have insurance, there would be a state fund that would reimburse for those visits. Are there any questions or comments about that bill? And sorry, one more note on the status of this bill. It was dropped last session. It didn't pass, but Senator Becker did get it put in as a pilot in the budget right now. So it is a pilot, and Ian, we're still waiting on an update on it, but it's for, so the budget goes for 2 years. So the pilot will last 2 years. That'll develop the training and implement it into 3 school districts, and they'll be able to run it for 1 year, presumably next school year. So.
I had a quick question. Is this just exclusive to psychologists or any mental health worker who's licensed?
No, and I'll need to look at the text again, but I use the word psychologist. I don't think it's limited to psychologists, but those who would be qualified to treat students in this situation. I think you guys would be the experts on that more than I would. So if you do have recommendations on what language
I would
that
like
should
to see the bill, and then I think we shouldn't limit it to a certain, but maybe it's not limited.
I don't think it is.
Maybe any licensed independent practitioner that is qualified to see a child with mental health concerns.
So Joe, that might include like LCISWs, licensed.
Exactly, like mental health
workers.
nurse practitioners, even a physician assistant.
Do you want to email me some language that might be good for that? And then, because I know that's in line with what Senator Becker would like.
Can we send the bill out and then I can look at it and then we have it? Okay, I'll go look at my email.
Yeah, I think it's what Nicole
Great.
said.
Okay.
It would seem to me that most kids would be covered under Apple Care or Apple Health anyway, so there should be a payment mechanism through that. So does this bill authorize that they can get reimbursed?
Right. So Apple Health would be one of the forms of insurance that could be reimbursed, which would cover a lot of students. But unfortunately, there's still a segment of students who fall between the cracks somehow that don't have any insurance. So presumably the students that don't have any insurance would hopefully be slim and small, but there are a few out there that it provides for those students to get reimbursed for through a state fund.
Stafford, I mean, this is a question as much for Mark Lowe at Seattle Children's and for Cara Tal here. How does this fit in with the other kind of psychiatric telemedicine programs? I know there's the PALS line at Seattle Children's and some of the other things that have come out. Do you feel like this fits in well with that? Or
Yeah, this is Mark. So we do have the PAL line, which is going to primary care providers, PCPs, connecting them with a psychiatrist or medical management help at Seattle Children's. And I think under a grant are doing some school, they're going to start launching a school PAL program as well, similar to this, but it's very limited in scope. And so this would be definitely helpful along those lines. Same sort of idea.
Language in the bill says psychiatrist.
It says in the psychiatrist, yeah.
Yeah.
Which page are you on?
It's page 3, and then page 4 they talk about second visit.
It's like page 3. There's just a note by Dr. Goff that psychiatrist gets mentioned as the.
If you look at that section 2, you can see that.
Middle of the page.
Yeah, if Joel, if you want to send language maybe that would be more appropriate there, I can approach Senator Becker and because she would be the one that would decide.
I don't have too much to add to that, just to say that, historically the psychiatric services have been really separated between UW Adult and Seattle Children's for pediatrics. And I think because of the telemedicine thing and the call lines and things like that, we are actually coming together more and working together. So we have a kind of a comprehensive plan and idea, and we know what, the left knows what the right, or the old knows what the young is doing. So yeah, it's been helpful.
That's great.
Representative Schmick.
I should have printed them out and brought them with me, and I didn't. Who's responsible for getting the training out to who's developing it, and how is it getting out to those districts?
So the bill language, the striker says University of Washington in collaboration with Project ECHO.
Okay. That's how they're going to get it. Are you going to be by the content?
I wouldn't.
But I'm asking, who's providing the content, the training?
Yeah, I think it would be in collaboration with Seattle Children's and the Department of Psychiatry here.
And I think another is to produce the training and then perhaps do it during professional training days that they currently have training and do training on now.
Thank you.
So if you have any other comments for with regards to this bill, maybe if you can send them to Stafford and copy Nicole, myself, Representative Schmick, and the other legislators. Is that okay, Stafford?
Yeah, and if you could do it in the next 2 weeks. Committee days are coming up in a couple of weeks, and I am presuming that Senator Becker is going to be talking about this bill, so anything before then would be beneficial, though I don't think she's actually going to drop the bill until December sometime.
So just a quick question. So the most recent copy I have is from August 22nd. Have there been any edits since then?
That's probably and that's the same copy we discussed at 2 telemedicine meetings ago. There was some language recommendations that came in, but Senator Becker wanted to stick with what she had. But I don't think this specific request was great.
Right, and what was that bill number?
5389.
5389, okay, so then we're going to move on to 5385.
So this is the payment parity bill. It is somewhat lengthy, but it's the same type of language that's amended in 3 different parts of law. This one dictates that telemedicine visits will be reimbursed at the same rate as if the visit was provided in person. And that's how, that was pretty much the bill as it started, but a couple of changes came later on and throughout session. One is that reimbursement for a facility fee is subject to negotiation. So I know there was some talking here about facility fees, but that it allows for negotiation on that. And then it also allows for facilities that have 11 or more providers to negotiate a rate as well. But for 10 or less, it dictates that there must be parity.
And Stafford, where did the 10 number come from, or 11?
You know, I don't remember. I would defer that to Senator Becker. She has lots of meetings and I don't attend them all.
Copy.
But and I don't know if it came from another legislator or if it came from a stakeholder, but it seems like there was some consensus among parties that she was discussing it with around those numbers.
I'm just wondering if, Stafford, if you've been able to review the parity law that was passed in California like last week, and if there's any kind of material differences between that bill and this proposed bill.
I don't know.
Okay. I'm just wondering if there's lessons you learned from California.
That's, Dr. Scott, that's one of the questions I was going to raise. I'm not sure if you've received any notification about payers or health systems contracting with provider groups, creating what they call narrow networks. Does that sound familiar at all? I believe that's the one California difference.
Okay. Well, I'll tell you what, in terms of an action item, what we will do is we will send a version of that California bill for the collaborative to review in conjunction with this, just to see if there's maybe stuff we can learn from the California law that we want to throw in there. Is that okay, Stafford?
Yeah, and we'd welcome comments. And I know Senator Becker's open for comments as they come in, but please get them to me in the next 2 weeks, but next month for sure, if you can, and we can discuss them. Senator Becker.
And Stafford, in terms of this being heard in the committee, do you have a sense of when it might be heard? Is there going to be a work group in the fall here, or is it going to be probably more in the regular session?
So there's only one committee meeting before session starts, and that's committee days in a couple of weeks, and it's not on the agenda.
I see. Okay.
And as far as it getting pulled up for a committee meeting, that would be up to Senator Cleveland, who is the chair of that committee.
Okay. Right.
And Senator Becker, before we move on, did want to have me apologize that she couldn't be here. There was an unforeseen family circumstance. She went to be with her sister. Her brother-in-law passed away unexpectedly, and so she's there with them. She's traveling back today.
please pass on all of our condolences to her and her family. Okay. Well, any other last comments for Stafford or questions for Stafford before we move on to this agenda item? Okay, thanks for presenting that. Good. So I think Elliot Weiss is going to be up next. And Elliot, would you mind just introducing yourself and kind of your role? And I think we have you on the agenda to talk about the compact, the nursing compact. And just to kind of refresh folks, I think we've talked about it twice already at the collaborative. The deal with the compact language is you cannot change it. And what we talked about last time was there are a couple concerns about scope of practice and just making sure that nurses understand different scope of practice in the states. The other issue was around just any kind of notification to the home state if there was disciplinary action in the other state. So those are just some of the things that we are kind of grappling with. And Elliot, we'd love to hear your thoughts on that and other topics. So I'm going to turn it over to you, Elliot, and thanks for coming today.
Absolutely. Can everybody hear me?
Yeah, go ahead.
Yeah.
Great. Well, I'm Elliot Weiss, Director of Government Affairs for the National Council of State Boards of Nursing. First and foremost, I want to thank you all for inviting me to join. In particular, thank you to Denny, who we've worked really closely with on issues in the American Telemedicine Association. I also see a couple other people on here that I know very well, Christy Henderson in particular. Hello, Christy. I serve as Director of Government Affairs, handling all of our federal government and national in scope issues. So that's how I touch on the Nurse Licensure Compact. I've actually invited our State Legislative Affairs and Advocacy Director, Rebecca Foch, to also join us. She's been working with our folks on the ground in Washington State and across the country at the state level with all the states that have been working to implement the Nurse Licensure Compact as well as pass it. And she is by far the best person who can answer all the very specific questions about the Nurse Licensure Compact. I just want to reiterate that we're really thrilled to be a part of this. We're really excited about the opportunity for Washington State to potentially join the Nurse Licensure Compact, and we're eager to answer your questions. So with that, I will turn it over actually to Rebecca to talk a little bit about our work.
Great. Rebecca, the floor is yours. And if you want to unmute.
Maybe unmute, yeah.
Just go down the bottom left and there should be a little telephone.
Hello?
Yeah, go ahead. There you go.
Hi. Oh, there we go. Okay. Sorry about that. So as Elliot mentioned, my name is Rebecca Foch, and I do work with all of the states in their state legislatures to get the compact enacted. So currently we have 34 states, and I've worked in almost every one of those 34. We have 34 states that are a member of the compact. And I have been working with our lobbyists in Washington State. I believe our lobbyists, Jonathan and Patty C, did a presentation in August to this group about the compact. So I've been working with them and am very aware of some of the concerns that I think that a lot of people have, that some of the opposition has about the compact. So I'm happy to first and foremost address those questions that you had already brought up, but also to kind of talk through or address any other concerns about the compact. The compact's been in operation for about 20 years now. So, you know, that's one of the best things about the NLC versus some of the other healthcare licensing compacts. It's not new. You know, we have a long history, and some of the concerns that some of the newer states are worried about, we know that we haven't seen them to be a problem. So that's kind of helpful as we kind of try and get more states into the compact, because we have this track record and all of this experience to kind of to help us along the way, if you will. So with that, I thought maybe I could start with the issue of the scope of practice, that how nurses would understand scope of practice outside of the state. Is that okay?
Please do. Go ahead.
So the one good thing about nursing is that the RN and RN licensure is pretty uniform across the country. Not completely, not 100%, but very close. All nurses take the same test before they can become licensed in the United States. It's called the NCLEX. The education is substantially similar from state to state, hence why you can go to nursing school in, Texas and then have no problem getting licensed in, New Hampshire. And, generally the scope of practice for a nurse, for a registered nurse or an LPN, which are separate scopes, but generally they are the same across the country. There are exceptions. There are certain states that have carved out certain things that might be different from others, but generally they're the same. We like to point that out because unlike, for instance, advanced practice registered nurses, if everyone's familiar with that role, their scope of practice can differ drastically across the states. With an RN, that's really just not the case. So in the 20 years that the compact has been in existence, we had never had an issue with a nurse traveling to a new state, not understanding scope and doing some sort of procedure or something along those lines that she wasn't educated or capable to do. So it just isn't something that we've found to happen in these past 20 years. That being said, just like if a nurse, so right now, if a Washington nurse, for instance, wanted to practice in Idaho, she would apply for endorsement in Idaho for a nursing license. And, she wouldn't take any sort of specific Idaho test. They would check to make sure she passed the NCLEX. They would check to make sure she graduated from nursing school, check to make sure that she doesn't have any active discipline, and then issue a license. So it's not, in that sense, it's really not even different from what's going on now. It's up to the nurse to know what she can and cannot do and what is within that scope of practice, in the state that she is practicing in. So it's up to the nurse, and usually it's the nurse and the employers that kind of address that if there ever is an issue, but we have never found that there was one. Is there any follow-up questions to that specifically?
So Rebecca and Elliot, we're fortunate to have two nurses here in the room. So maybe I'll see if Cara or Joelle have any concerns, and since you are trained as nurses, can you think of any situations where, maybe it come up?
Well, just, so thank you for that, Rebecca. I think the NCSBN does carry a different position than the states independently. I think, the overarching idea that nurses are trained interchangeably is the concept is certainly accurate, and nursing schools are accredited, and there is standardization across nursing schools in terms of the educational rigor and content. And we do sit for the same NCLEX exam, similar to Canada. But the scopes of practice can vary state by state. And I think that that's the most important thing to sort of put out there, is that nurses do have variances across each state in their scope of practice. And that's where things start getting a little bit sticky with compact agreements and licensure in terms of understanding what rules the nurses follow. I'm licensed in 2 other states and have practiced across Washington, Idaho, and Alaska. And it is on me as a licensed independent practitioner to understand what those rules and those laws are in those states. And so I think creating that awareness and that responsibility, really emphasizing that is really important, because none of us want to get into trouble when we're practicing in another state, and that's our biggest concern. I would also say there's been a lot of question around, if there is a practice issue, who's responsible for disciplinary action. Do you have any comments about that, Rebecca?
Oh, yeah, sure. Yeah, absolutely. So it depends where that disciplinary issue takes place. So the way the compact operates, the practice of nursing takes place where the patient is. So wherever, then that's where it kind of gets a little tricky when you're using, not tricky, but when you're using telehealth, that's especially important, because if you are a nurse practicing telehealth, let's say in Washington, but your patient is in Idaho, the disciplinary process will start in Idaho, because that's where the patient, received, that's where the discipline would take place, if you will. So the initial investigation, it will all take place within Idaho, because they would have the kind of the opportunity and the resources to investigate whatever happened, in their own state. Under the compact, Idaho, well, first off, under the compact, as soon as Idaho opens up that investigation, once they have to tell the state where that nurse is actually licensed. We call that the home state. They have to notify that home state that, say, hey, your licensee is under investigation. We want to flag that for you so that you can be a part of this and know that this is kind of going on. The state where the action took place will do the investigation, and then under the compact, they are required to share that information with the home state. So again, the state where the nurse is actually licensed, even though the action didn't take place there, because that's, even though it didn't take place in that state, since that's the state where the nurse is licensed, that's where any discipline on the actual license will need to take place. So between the two states, Idaho can do their own kind of due process, and Idaho could say to that nurse, let's say the nurse was caught diverting drugs, medication, whatever. So then the Idaho would say, we feel we are going to revoke your privilege to practice in our state because we investigated this and we found that you are diverting drugs, and maybe they would have to go to some sort of a treatment program, and at the end they can have that, they can get their privilege to practice back. But for the time being, we're going to suspend or revoke your privilege to practice. And then Washington, where the nurse is actually licensed, the Washington board would then be able to take discipline on that license based on what happened in Idaho. Okay. So Washington, most likely in that scenario, would say, we're going to suspend your license until you're done, let's say, with a treatment program. And when Washington suspends that license, the privilege to practice under the compact is suspended. So it would be suspended in all of the states in the compact until whatever discipline that was issued is completed.
Thank you. That was very descriptive. Final question. So we're talking about registered nurses. What about the practice of advanced practice nurses, and who? Yeah. Mm-hmm. Go ahead.
Yeah, sure. Yeah. Advanced practice nurses, or APRNs, that is a separate compact. The NLC only applies to RNs and LPNs. The main reason for that is because, as you had mentioned, there is a lot of uniformity with RNs. There are some differences, but more so uniformity. That's unfortunately not the case yet with APRNs. Scope of practice in some states is more liberal, like Washington, and then in some states, particularly states in the South, their APRN scope of practice is very restricted. So because of that, it's very difficult to implement, or I shouldn't say difficult to implement. It's kind of just a different beast, and it's a different license. So that is a separate compact. We do currently have an APRN compact. There are 3 states in it. But there may be some changes along the way for that. So unlike the NLC, it's not as established, and there aren't as many states that are even really able to participate. And it hasn't started yet because it hasn't even reached its threshold amount of states that it would need to begin operation. So
yeah, that's
that
great.
is, yeah.
Thanks, Rebecca. You did a nice job describing that. Thank you.
And this is Elliot. I want to add one thing to what Rebecca said, and that's that in a lot of states, you have to have an RN license. Actually, in every state, you have to have an RN license as a prerequisite to obtain your APRN license. And oftentimes what can happen is that RN license or that privilege to practice in a nurse licensure compact state can serve as that prerequisite to obtaining an APRN license. So you wouldn't necessarily, for example, if Washington were to join the compact, need to obtain an RN license first in order to obtain an APRN license in the state of Washington. It can serve as that prerequisite. That multi-state privilege to practice or multi-state license can serve in that role, which is something I think is an often lost interface to the nurse licensure compact for APRNs.
Other questions? Representative Riccelli, do you have any concerns or questions for Rebecca or Elliot?
No, that was helpful, and I've been working, with Jonathan and Patty, and been meeting with members too, and particularly just a reminder that my community first brought this to me really out of interest for our military communities and military spouses. And actually, Illinois just passed a pretty sweeping bill, is my understanding, around some of these licensing arrangements, particularly for military spouses. But because I also ran the medical licensure compact and am on the telehealth collaborative, I can see a lot of potential benefits. And I'm doing what I think others are doing. We're just taking questions one at a time and trying to address them and see how we can make this work moving forward. And I just appreciate the kind of back and forth and the educational opportunities, and certainly am interested in hearing concerns. I'll say that I should have a bill, which I'm happy to share, that will be circulated around our committee days, which is coming up in a couple weeks. And sounds like Senator Cleveland is going to continue to carry her original bill that was introduced last year, but my guess is we'll be working to have the striker of the new language there. And then we just continue to work through questions back and forth, and obviously I don't know all the answers, so it's great to have folks that can help dig a little bit deeper as these questions come up.
Okay, great. I just want to make sure we're all comfortable with the education that's going to go on about scope of practice at the time you apply. Is there some way that, let's go back to the example of Joelle, you're got a license here in Washington, but you want to practice in Idaho. Is there any way that Washington State could say, okay, we see that you're applying this, please know that there might be different scope of practice there, and it's incumbent upon you to learn those. And here's some research to go to. Is that something we can do on our
I don't know if we want to get into that.
Yeah.
That would be a heavy lift for this collaborative. I can just say, having been licensed in these other states, both RN and ARNP licensure, they send you booklets, and it's on you to review the rules and the laws, and to track what changes over time.
Okay.
Which would translate to any specialty, right?
Yeah.
Any licensure, MD and otherwise.
Yeah. But it's not like a driver's license. Like when I go to get a driver's license, I have to take a test, right? There's not that test there. So, right. Any other questions or concerns?
But it is.
Yeah, go ahead, Rebecca.
Well, I would just add, though, it is very similar to your driver's license in that, you know that when you cross a state line, the speed limit, may change, or, you may need some sort of, off the top of my head, their DUI laws are different. You may not know necessarily that what they are. It would be your job to look into it. Hopefully you would never be driving intoxicated, but you know what I mean? But it's not as if when you cross a state line, you just assume that all the laws are the same. It's incumbent on you to know and to change and to adjust the speed, etc. So you do take a new test when you maybe apply for your new license somewhere in the driver's license. I'm not sure. That might be state to state, but it does operate similar in the driver's license in that, there's no kind of pause or stop. You're able to practice immediately, but it is up to you to know, what you can practice or not.
The one thing that might be helpful is to, as we continue to mature as a collaborative, is to direct our nursing colleagues to the variances in how they may practice across state lines as it relates to telehealth, depending on the laws in the other states, since there's so much variation in practice across state lines.
I just wonder, as part of the compact, is that something that they can facilitate for people who are members of the compact to have some sort of a resource or a, alert system that, something has changed in this state and you should be aware of it?
Yeah, because I know as a physician, we get quarterly newsletters from the Medical Quality Commission about new changes. I guess the most recent one was like suicide training that comes up.
Yeah.
You hear about disciplinary actions and things like that. So it'd be good to get a newsletter if you're in that state.
Yeah, and you do.
Yeah, you do.
They
Okay.
said.
Yeah, so that's one way to keep up. So I have
If
a
I
little
could
Go ahead.
John, if I could clarify, the one thing that I heard that seemed striking, is it true? You said, that in some form the compact has existed for 20 years. So there's never been a problem with scope of practice.
No, there
Is that
hasn't.
true? I mean, is it?
I mean, I don't want to say that no nurse has ever been disciplined for that in 20 years, but that very well could be so. But no, we've never had the states have that come up as an issue or have the commission have to kind of do anything to address it. And again, I just want to, I know that there are some differences in RN practice, but the real, kind of extreme differences between practice is with the advanced practice nurses. So, making sure to remember leaving them out of it. When it is the RN only, there doesn't seem, we haven't experienced there to be any issues in that realm.
Joelle, you think Washington State would be different?
That's a great question, and our colleagues here at the Nursing Quality Assurance Commission and the Washington State Nurses Association have been examining this. There are some leaders in other states who have found the lines to be a bit fuzzy when it comes to practice across state lines, and the compact has been a point of contention for people who have entered into that. I think that we all have to just walk very carefully and make sure that our eyes are wide open. I'm on the one hand very excited about how this will open up practice, but we're talking about our licenses and patient safety and livelihood of these nurses. So I don't take it lightly. I'm vaguely answering your question.
Sure. No, I hear it. Sounds like it's had a good track record of working so far, but you need to be very vigilant, you're saying, going forward to make sure that continues.
It's fuzzy.
This is Representative.
And some of it is the importance of reporting across state lines and making sure that communication gets back to the home state where the nurse is licensed. I think that this is, like I said on one of our last meetings, this train has already left the station. We're on our way. I think we need to be good stewards of this legislation, and we need to monitor it carefully.
This is Representative Riccelli. I did think of one question. I feel like it's as a sponsor, it's a valid question to ask. Hopefully somebody can maybe give us some insight. I was told by some folks that, there's kind of what we're dealing with now is kind of the nursing licensure compact version 2. And there were a couple of states that were in the original compact that didn't decide to continue on. And I was just wondering if you could provide some insight into as why. And,
sure.
And maybe validate that that's correct information or not.
Sure. Yeah. It wasn't a couple. It was one. Rhode Island is the only state that didn't move. So yeah, there were 25 states in the original compact. 24 of them moved to the new 2.0, new compact, and that new compact now has 34 states, just to kind of put that in perspective.
Great.
For Rhode Island, it was a so there's kind of a couple things to do with Rhode Island. So unfortunately, we kind of have we have some holes in the country if you look at the compact map, and one of them is kind of a handful of states in the New England area. And Rhode Island has a very strong union presence, and the union in Rhode Island did oppose it. So that is why it didn't continue. They were the only ones that didn't continue. Every other state did pass the legislation again to be in the new compact.
Okay, thank you. And I just wanted to reiterate for the group again that from our, I'm trying to look at this broadly and how I've come out with, but it really initially came to my attention through our military families, and lots of other states are doing all kinds of things around licensure to help our folks who are serving, but also their spouses. And I am really, really confident that if for some reason this thing got scaled just to military spouse, it would sail through. And there have been some issues with turning those licenses around. They're supposed to kind of get front of the line, but I really want us to look comprehensively, because I feel like that would be just piecemealing another thing. And I also see some of the broad benefits, but we have, like the Secretary of Defense has supported this from an economic development standpoint. When bases go through BRAC, these are the types of things they're now looking at. So I think this is important on a number of fronts. And I am, again, committed to doing it right and making sure that we're answering all these questions step by step. And I can't tell you how appreciative I am that we are having, what is now the third conversation with this group. And I know it's taking some time, but I thank everybody for participating as we try and navigate this.
Great, thanks. So I'd like to have a vote on the idea of the compact. And so we do have some time later in the session to do some other voting, but since this is still fresh in our brains, if it's okay, I'd like to take a vote now for those who are in support of the compact and for those who are not. You can abstain if you want to have more information, but if you can please raise your hand if you're in favor of the nursing compact.
People on Zoom do.
What's up?
What should people on Zoom do?
So if you're on Zoom, you can text in, you can chat in. If you're on the phone, please say aye. But in the room,
aye.
Aye. Aye.
Aye.
Aye.
Hey, Dr. Scott, I just have slight concerns about not checking with my colleagues at our health system. I would love to be able to see it individually.
Okay, we'll put you as an abstain. Okay, great. In the room.
Sorry, who was that? Was that Denny?
Yeah.
It was Denny.
Denny, I'm going to come talk. No, I'm just kidding.
You know where I live, yeah.
In the room, yes.
I'd like to put it off for right now. I just need to do a little deeper dive into it. Yeah.
And all those say no? And all those abstain? All right, so I think we'll do the final tally. We didn't have any no's, but we had at least 4 abstain that want a little bit more information. And I think maybe what would be helpful is to see Representative Kelly's bill and having a little bit more conversation with some of these remaining issues.
Will we be able to look at that?
Yeah, Representative Riccelli, do you know when you might have a draft of that bill? I mean, I know it's pretty boilerplate.
Yeah, no, it's, I think I should have it. It should be back from the code advisor pretty quickly here. And we sent out the last version, but I'd love to just wait till, whatever the one that's going to have a signature sheet, at least for now. And obviously that doesn't mean there aren't potential changes that could go through, but I thought it was important to have something around committee days and to consider pre-filing it. So I can send you that version pretty quickly here.
Okay, great.
If you send it out, I'll definitely look at it as a nurse. I'd love to see it. Thank you for that.
Great.
No problem.
Well, Elliot and Rebecca, we thank you for dialing in. I know you guys aren't on the West Coast. This is kind of a late afternoon meeting for you. So thank you very much for your expertise and joining us.
Not a better place to spend a Friday afternoon. And let me just say thank you to all of you for having us on again. And we recognize that this is an ongoing process, much like Representative Bertelli said. So if you have questions, we're more than happy to continue answering them on an ongoing basis. This is certainly a complex piece of law. We recognize that, and we want to make sure everybody's comfortable with it. So if you have questions, shoot them our way. We love to have them.
Okay, great. Thank you, Elliot. And Nicole, if you wouldn't mind just making sure that his email is available to folks on the collaborative, so we can do that. Okay, well, thanks everyone. So our next agenda item is to hear from Dr. Ryan Sterling. He's going to talk to us about healthcare spending in virtual urgent care. So as a way of introduction, Dr. Sterling is a recent graduate from the PhD program here at the University of Washington in Health Services Research. And I was fortunate enough to be on her PhD dissertation committee, and she did such a great job and was so informative. I asked her to come and give us an overview of the research she did. And so, Ryan, do you want to take it away? And I have the slides. If you just want to tell me when to advance, I can advance them for you.
Oh, okay. That may be slightly annoying for you, only because there's a few layers on each slide.
I know your slides pretty well. I've heard your presentation before.
If we can do it by mouse, maybe that would be easiest. Okay. You do know my slides quite well. I've made it much shorter. He had to sit through a 45-minute presentation a few months ago.
Just double check it works. I'm not sure.
Oh, yeah, good call. Oh, yeah, okay. Okay. So should I just go ahead and get started?
The speaker's right in front of you. So.
Okay, great. Yeah. As Dr. Scott introduced me, my name is Ryan Sterling. I'm a recently graduated doctoral student here at the University of Washington. And I am so honored to present my dissertation research in front of such a knowledgeable group. Thank you so much for having me. And I guess as an introduction to what I'll be talking about. So this is one part of my dissertation research, but I'll be reviewing patterns of healthcare spending and service utilization associated with one emerging form of telemedicine called virtual urgent care. So in 2018, more than half of all hospitals and health systems in the United States offered some form of telemedicine. And based on recent national surveys, among those organizations that offer telemedicine, a hospital is currently the primary setting. But looking forward, what is of increasing priority to health organizations is to provide home-based telemedicine services that are accessible to patients on demand and in real time, such as for primary and urgent care or post-acute specialty care. And for the purposes of my research, I've classified these types of telemedicine services as on-demand telemedicine. And current rates of adoption for on-demand telemedicine are still quite low. But looking into the next 3 years, upwards of 80% of those health organizations surveyed are highly interested in offering these types of on-demand services to increase access to care, reduce unnecessary service costs, and extend brand recognition, among other leading drivers. And while the value proposition for on-demand telemedicine is quite promising, relatively little empirical data is currently available to evaluate its impact on healthcare spending and service utilization. So to help address that gap, my research leveraged patient-level data collected from early adopters of health organizations of one particularly dominant form of on-demand telemedicine, which I call virtual urgent care. So virtual urgent care clinics, or VUC, provide real-time virtual visits by phone or video that are initiated by the patient, accessible on demand, and are typically a one-time service encounter not associated with the patient's established care provider. VUC services are deemed clinically appropriate for the treatment of many low acuity or minor illnesses and injuries that can be treated remotely, such as a sore throat. And the service also offers transparent per-visit pricing and low out-of-pocket costs for consumers. And I know locally, UW-Medicine, Virginia Mason, Providence, likely representatives of other organizations around the table here today offer this type of virtual service. But for those of you who may not be very familiar, so what does a VUC visit look like from the patient perspective? So a patient in need may learn about the availability of VUC via a range of sources, such as an internet search. And a patient can initiate a request for a VUC visit using a web browser, phone, or tablet. And after completing an online intake form, a patient will typically connect with a virtual provider within 10 to 15 minutes. And then based on a patient's chief medical complaint and medical history, the provider will either treat the patient through the virtual visit or, if clinically indicated, triage that patient to a form of in-person care for recommended follow-up. And a virtual provider can prescribe medications as part of this encounter as well, excluding opioids and other controlled substances. So my dissertation research was part of a project that was funded by the Center for Health Organization Transformation in association with the National Science Foundation. And the objective of that overarching project was to essentially build a data inventory to examine patterns of healthcare spending and service utilization associated with VUC. And we engaged with multiple partner organizations to build such an inventory, which now consists of millions of patient-level records. And our partner organizations included 2 self-insured 501c3 health systems operating in the Midwest, a Medicaid managed care company here in Washington State, and a national telemedicine vendor company that contracts with these other health organizations to outsource the VUC service, including both clinical staffing and technology infrastructure. But the research I'll be sharing with you all today focuses specifically on our self-insured patient population. So I'll be sharing findings from 2 studies I conducted using the data inventory, and these are both retrospective cohort studies that targeted a study population of continually enrolled members of self-insured health systems that offer VUC as a fully covered plan benefit. And our data sources included medical and pharmacy claims, beneficiary enrollment files, and virtual encounter files, all available from fiscal year 2015 to 2018. And we also linked county-level socioeconomic data from publicly available sources. So our first study looked at diagnosis-specific differences in cost and service utilization between VUC and comparable in-person services. And to do this, we considered a study sample of all self-insured plan members, both adults and children, who used any outpatient or emergency services within the first 18 months after VUC became available. And then from that sample, we constructed 2 cohort groups based on whether services were initiated with a VUC visit or an in-person visit. And in-person visits could include an office visit, urgent care, or ED visit. Our outcomes of interest for this study included total costs, focusing on the paid amount, and also any clinical follow-up. And we used a propensity score method, rather, which likely, well, I'm happy to talk about it more, but anyway, a propensity score method to balance baseline differences between VUC users and in-person users. And then we estimated our diagnosis-specific outcomes using common regression modeling techniques. And importantly, sorry, it's kind of cut off on the bottom there, but our unit of analysis for this study was an episode of care, and that was defined as an initial virtual visit plus any outpatient or emergency services received over the next 28 days with the same primary diagnosis. So our second study looked at patterns of follow-up care and associated costs among VUC users. We considered a more limited sample of all self-insured plan members that used VUC services in the first 18 months after becoming available. And then we constructed 2 cohort groups based on whether an initial VUC visit then resulted in a follow-up visit to an in-person care site versus not. So for this study, the intent was to identify demographic and virtual visit predictors of any clinical follow-up, and then based on those identified predictors, estimate total costs, again, using common regression modeling techniques. And our unit of analysis was the episode of care again for this study. So getting into our data, here we're looking at general VUC episode characteristics from our 2 studies, starting with user demographics. The average patient age was 32 years. The majority of patients were female, resided in urban areas, and had a low disease burden. And compared to VUC users for in-person services, users tended to be older, sicker, higher proportion female, and higher proportion urban residing. And I'm just pointing out this comparison to underscore the importance of our use of propensity score methods to balance those baseline differences between VUC and in-person users. So here we're looking at initial virtual visit characteristics among VUC episodes. About 1/3 of all visits occurred on the weekend. The majority of visits occurred either during the working day or overnight. Half of all visits were delivered by phone. About 30% of visits were delivered by a video-based app offered by the sponsoring health system, and about 20% were delivered by FaceTime. Sorry, again, it's cut off on the bottom there, but very few visits were delivered using Skype. Regarding medical diagnoses, more than half of all VUC episodes were for acute upper respiratory infection, urinary tract infection, or some other form of respiratory system diagnosis. About 60% of all initial visits involved a prescription for a medication, 20% for an antibiotic prescription. And as assessed by the virtual provider at the time of the initial visit, about 55% of all VUC episodes were considered clinically managed and did not receive a referral to an in-person site for recommended follow-up care. Meanwhile, about 38% of visits did receive a referral to an in-person site for recommended follow-up. And I point out those 2 categories of VUC episodes because they become important in our second study that looked at patterns of follow-up care among VUC users. And finally, about 12% of all initial VUC visits did result in a follow-up visit at an in-person site. So for our first study, we found that for the most common low acuity diagnoses, episodes of care that were initiated with a VUC visit cost less and resulted in a lower rate of follow-up visits as compared to episodes that were initiated with an in-person visit, again inclusive of office visits, urgent care, or ED. And the figures displayed here go into a greater level of detail for our regression model estimates, but to give you a high-level interpretation of what's going on. For urinary tract infection or UTI diagnoses, we found that compared to in-person episodes, VUC episodes were on average $370 lower in total cost and were 53% less likely to result in a follow-up visit. And for respiratory system diagnoses, we found that VUC episodes were on average $516 lower in total costs and were 66% less likely to result in a follow-up visit. So these figures are looking at respiratory system diagnoses in aggregate, but we also did a number of subcategory analyses that looked at individual respiratory system diagnoses, such as influenza and acute upper respiratory infection. And those analyses revealed very similar trends. So here we're looking at findings from our second study of patterns of follow-up care and associated costs among VUC users. We found that for episodes that were referred to in-person services for recommended follow-up, only 15% of those episodes actually resulted in a follow-up visit. And that finding may suggest that many VUC users are not receiving follow-up services that may be needed to fully resolve their clinical symptoms. We also found that adherence to recommended follow-up actually lowered per-person healthcare costs among VUC users. We found that among episodes that received a referral for recommended follow-up, receipt of follow-up was associated with $128 lower in bless you.
There's a virtual visit for you.
I'm not going to prescribe anything for you, though. Just to wrap this up, so meanwhile, for those episodes that did not receive a referral to an in-person site, about 10% of those episodes resulted in a follow-up visit. So the result there may suggest that VUC does not unduly increase service use if follow-up is not clinically indicated. Although we did not find any significant cost differences between our cohort groups for that category of VUC episode. So what are the factors driving the patterns we're seeing in follow-up care? For the demographic and virtual visit characteristics we considered, we found that age, rurality, visit delivery type, visit length, prescription medication status predicted the likelihood of follow-up among VUC users. So,
before you move on, could I just ask on that last slide there?
Yeah.
So you're saying that if the patient received the recommended follow-up, they spent on average $128 less total?
Yes.
For that particular illness diagnosis?
So for all additional episodes of care received for our time period of interest, which depending on the patient could have been up to 18 months.
Okay, thank you.
Does that answer your question?
Yes.
Okay. So to wrap things up, what are the key lessons we can take away from this research to impart to organizations that may offer this type of virtual service or may be currently considering launch? First, we found that, at least in the context of self-insured health systems, VUC may be able to serve as a low-cost alternative to in-person services for very common low-acuity medical diagnoses. Second, our results suggest that VUC can resolve patient symptoms for those low-acuity medical diagnoses without the potential need for duplicative follow-up care. But then lastly, we did find some evidence of a disconnect between the VUC visit and in-person follow-up care. Many VUC users are not receiving recommended follow-up, and we found cost implications associated with this. So looking forward, what can organizations do to better capture value from the VUC technology? First, there's need to improve continuity of care between VUC services and existing health system structures in order to facilitate appropriate follow-up care when it is needed. And building from past research my team has done among VUC adopter organizations, in order to improve continuity, there's evidence to suggest that organizations should implement standardized post-VUC encounter processes. And moreover, these processes should create a warm handoff between the VUC visit, which in this context is provided by a virtual clinician that is employed by a telemedicine vendor company, and follow-up care, which is most often provided by a sponsoring health system. And integrating the clinical integration of the VUC encounter into a health system's EMRs and other electronic systems has been shown to aid in this effort. And then secondly, evidence suggests that organizations should focus on raising awareness for the VUC service. And raising VUC awareness is needed to drive uptake as well as to capture greater market share. And then additionally, to facilitate this idea of right time, right level care. And in order to increase VUC awareness, at least our research suggests that marketing is key. And in addition to direct-to-consumer marketing to provide consumers with an understanding of the availability of VUC services, and as well as to educate them on the medical situations where VUC may be a good option, marketing efforts should also focus on essentially selling the health organization, because this is where a strong connection needs to be made to make the consumer turn to the health system's VUC offerings as opposed to other options that may be available to them. So in this way, organizational branding is also very crucial for raising VUC service awareness. So I'll stop there. Thank you so much for your time, and I'll definitely take any questions you have.
Great, thanks, Ryan. All right, I'm wondering if you could go back to the slide that shows the cost saving for the various modes of service. I'm going to go back to it. It's this slide here, and the urgent care, it was only $100 of cost savings versus the VUC. It was kind of least spread there, and it's kind of a little bit counterintuitive. I expected to be closer to the emergency department. Can you speak to why that is? Why they're kind of a little bit of a anomaly in that pattern?
Yeah, well, so are you surprised by both the urinary tract infection and the respiratory system diagnosis?
It's mostly the UTI.
Yeah.
I think you see more of there's a little bit of a trend for respiratory, but the UTI, this is in general, ED is most expensive, followed by urgent care, followed by
Yeah.
doctor's office.
Right. So, you know, I'm sure I can't answer your question completely, but I have thought about it. One potential option is we only receive data from the insurer of these patients. So it is possible perhaps they're going for diagnostic testing to some out-of-network source. But yeah, I know you've mentioned that in the past, and it is a little bit surprising.
Other questions for Ryan?
I wonder if you, in your surveys, asked patients what they would have done had they not sought care this way, in other words, right time, right level of care, and whether or not this increases access to care and decreases ultimate costs to the systems.
Yeah, so the work that we did here is solely based on quantitative data collected from the hospital system in the form of claims data. So we didn't do any survey work with patients to get at that question of what they would have done otherwise. And I know a number of leading telemedicine vendor companies in particular have done that survey work. So unfortunately, I'm not able to answer that question.
No, that's good. Thank you.
For the
Move to the table.
Sorry?
I'll just...
How about we take the person who was asking the question on the phone first?
Yeah, let's go to the phone, and then we'll go in the room here. It's a male voice.
It wasn't me, but I think that was, I do have a question, if I can steal that person's time who I don't think is asking.
Please go ahead. It's hard to know when you're on the phone. Go ahead.
So this is Representative Chile. I just had a question, and it's not directly related to what you're presenting, but as you were doing this research, et cetera, did you come across much around virtual urgent cares and large employers? Because I know that's there's a lot of that going on, kiosks and virtual urgent care. And I was just, maybe it's something offline I could talk to you about, but I'm really interested in how large employers are engaging with virtual urgent care. Did you come across anything?
So I do believe there's been some published research, especially in California, around, I think it's I don't want to butcher the information, but I think it's a large state employer that has done some work in this area. But in one way, this research is novel because it's the first to really look at these types of results in the context of a self-insured organization. Now, the fact that this is a self-insured health system is perhaps, you can't generalize that to other self-insured organizations per se. But you know what? I will follow up with you offline and share some resources with you if you're interested in that.
Definitely. And I think you hit on where I was headed with looking at large employers, including state agencies, using these.
And Representative Chile, I just want to let you know that we had Christy Henderson on the call. I'm not sure if she's still here, but Christy is a colleague who just joined Amazon and is involved in the Amazon Care telemedicine product. And I'm sure she has some opinions on it, but before that came from Ascension and the University of Mississippi and has experience outside of the Washington State. Christy, are you still on the call?
I am.
Oh, good.
Hello. I've turned on my video. I'm back. Yes, I am. So yeah, glad to jump in and look forward to meeting everybody here as well. So, would love to work with you all on this. I do have some experience in this space.
Great. Francis, did you?
I could ask some initial demographics you had on there, like the disease burden of the two different cohorts.
Yes.
Right. So the VUC had a low disease burden, 99%. What was the disease burden in the in-person cohort?
Yeah, so it was still quite low. It was in the low 90s. And I just want to make it clear too that it is kind of surprising to see such a low disease burden. That's based on something called the comorbidity score. And my thought on kind of those proportions is that this is a very young, healthy typically, by and large, young and healthy patient population. So you're not going to see kind of high comorbidity numbers. So that helps to explain that. But yeah, in the in-person user cohort, we also saw fairly low disease burden, but not that low. I think it was maybe 93% or something around there.
Okay, not exactly the same, but still quite low. Great,
Right.
thanks.
Francis, you had a question.
Thank you. So I just had a question that's very interesting about the warm handoff to the primary care providers, presumably. But were there documents that were sort of like visit summaries that were sent to the PCP? So this would be an additional layer of sort of form transfer or hand holding versus just the summary submission?
Yes. So for the organizations that participated in this research, there was, I think it's called a CCD document, continuity. Yes, exactly.
Yeah.
And often, for at least the organizations that participated in this research, there was very low clinical integration between what the virtual provider could see. Like, they couldn't see a patient's electronic medical records or upload anything themselves, but a document was, a visit summary was sent to the sponsoring health organization, which presumably was uploaded into the EMR. But there's a lot of standardization differences across health organizations. I will say that before this project, we did some qualitative work that was basically a landscape study where we looked nationwide at early adopters of this type of virtual urgent care service. And nationwide, there's a lot of inconsistency in what happens between the virtual visit and getting that patient back to a physical system and back to their primary care provider if they have one.
We had a question over here.
Yeah, did you guys look at, because the follow-up was so low, whether that person ended up in the ED ultimately?
How long was your follow-up, basically?
Yeah, so so we were careful to only include VUC visits in our study that we were able to capture that full episode of care, so for that 3-week window. So it is totally possible that beyond that 3-week window, that patient is turning up into the ED for a similar diagnosis. We don't know that. We don't know for sure.
Would that be in the cost comparison or no?
So if a patient's visit fell outside of, that 4-week window, that 28-day window, then it would not be included in the episode of care, and it would not be part of our cost estimates. So that's certainly a limitation of the study. It's kind of hard to understand that cutoff point between one episode of care and another.
And Ryan, your other qualitative studies have been published, right?
So it has been accepted, but has not come out yet.
It might be helpful to collaborate when it gets officially.
Yeah, absolutely, absolutely.
Distributed. So this is super helpful.
And even I'll check with my co-author. I don't know what the timeline is, but just to confirm that she'd be comfortable, we could send out the current manuscript to the group as well.
Any other comments or questions for Ryan?
That was a great presentation. Thank you for sharing and all your work.
It was a lot of work.
Yeah, no, thank you all. There's so much more to be done. I wish I'd been coming to these meetings for the last few years. I feel like I'd have a much more contextual understanding of all of this. Although I have used the service before. Thank you all again for your time.
That's great. All right. Thanks again, Ryan. So we're going to move on to the next agenda item, and that's to hear from Cara Tell about the Northwest Regional Telehealth Resource Center, NRTRC. The annual meeting that was in Anchorage in August. So Cara, I'd love to hear kind of things you learned and any interesting findings there. And we're going to share here. So just let me know if you want to. We'll give you the clicker.
Okay, so we held our annual NRTRC, which is the Northwest Regional Telehealth Resource Center Conference, up in Anchorage, Alaska this time. we've held, I don't remember which number this is, maybe 6th or 7th one or something, 8th maybe. It's been a while. We held a lot of them in Seattle, and this was the first time that we held it in Alaska, and we had over 150 attendees, which is pretty good for Alaska. And the NRTRC serves all of those states listed. I click.
It just takes a second for it to click on the other side. This is like a regular mouse. There you go.
Maybe just click away. Don't give me technology. I can't do it.
There you go. Try one more time.
There we go. Okay, so just to give you an overview of what the conference looks like, we start out with a workshop day for the first day, and as you can see, we had USAC in the Rural Healthcare Program 101 sort of thing from 10:30 to 12, followed by 1:30 to 3, sort of a feedback program, which I did not attend, but heard that the folks who were representing there were very brave because they took a lot of feedback. And then the TTAC, the Telehealth Technology Resource Center, which is based in Anchorage but serves the nation, also had some showcases throughout the day so that people could come and, hands-on play with the technology and test it out. And then from 1 to 5 in the afternoon, we offered a Telehealth 101 workshop, which had a really good turnout. And I actually haven't seen the evaluations of it, but it was a really excellent program, very Telehealth 101. This is what you need to think about as you're setting up a telehealth program at various different settings. So that was great, and we had people from different states with different expertise presenting there. Obviously, you probably can't see this, but I did want to point out what the agenda looked like, and we really had a really good mixture of big programs presenting, like Intermountain Health and Swedish Providence, and smaller programs and pilot programs. And then we had people talk, actually we had our former board member, Sarah Orth, presented on how to influence state telehealth policy. So she talked all about the collaborative. We had Mei Kwong, who is the legal telehealth resource center. It's based in California, but it's for the entire nation. So it just had a really nice, broad representation of the different kinds of presentations. Let's see, we had participants from primarily Alaska, Washington, Oregon, and Utah. The farthest person we had was from a doctor from Morehouse School of Medicine in Atlanta, and his comment was, it was the best conference for an introduction to telehealth that he's ever seen. We learned a lot. So we got some really nice feedback, and I would encourage you all to come next time. Takeaways, I just jotted down a few takeaways that I really see telehealth evolving from what it used to be, where it was sort of a show and tell show when you would go to these conferences, and people are not only implementing, but they're really working on processes and looking at the financial sustainability. It's no longer just pilot programs and what outcomes they are. Really integrating within the regular healthcare delivery processes and workflows rather than having standalone programs. Focusing on not only replacing in-person care, but also enhancing the experience by using telehealth or digital health to provide more touch points with patients, between care, between team members, improving efficiency, promoting top of license care, like the ECHO programs really focus on reducing no-shows. So I just feel like it's such an evolving field. Still, some of the challenges that we heard through the questions were technology. Where do we start? How do we choose it? How do we support it? Risk management, cybersecurity, those kinds of questions were coming up a lot. Billing issues continue to be a problem or an issue. Some of the things that I learned there are that some of the payers are paying only when their own service is being used that they're offering rather than paying generically. And like we are asking here, they're also asking there, why are some of the direct-to-consumer program adoption rates so low? So, we're all sort of looking at the same thing. Questions. And just save the date that the next one will take place. We move back now to a spring rotation, April 14th to 18th in Portland, Oregon. So I'll be sure to put out more information and calls for presentations, which I would encourage you, Ryan, to look at.
Definitely.
So that was it.
Yeah, so I just want to make an additional plug for this meeting. It's one of the more cost-effective meetings, and it's quite a bit cheaper than the national ATA meeting. I think it's $200 around there.
Yeah, and it's because it's so small, it's a really nice opportunity to network and find out who's doing what within your region and really make connections.
Yeah, you can really have an in-depth conversation. And other benefits of the NRTRC is if you have questions, they are supposed to give 10 hours of free kind of consultation. The TTAC, that's the technical committee. So if you have a question like what technology should we, use, or if they have opinions on things like that, they also have free consultation. So this is your tax dollars, hard at work through these TRCs, and there's TRCs all around the United States. So sometimes you can go to other regions and they're having similar kind of meetings, and we'll have great resources. Do you know if they put any of this information, like the talks or anything, online?
Yeah, they're all online actually.
They're all online.
Yeah, you just go to nrtrc.org.
That's fantastic. Great. All right, any questions for Cara? Okay. All right, so for the next half hour, we've got a couple of things we want to go over. So you may recall we had 3 subcommittees that were meeting through the summer and part of the spring, and those committees were on research, clinical, and what was the third one?
Payment model.
Payment model.
Oh, it's research, patient education, and payment models.
Oh, thank you for that. And so those committees met and they came up with some ideas. And so basically what we're hoping to do for the next 20 or 30 minutes is to show some of the survey results and also get a little bit more direction from the larger group as to where these subcommittees should go with the next steps. And we're hoping that there'll be one big goal for each of these subcommittees. Do you want to orient us, Nicole?
Yeah. So about 2 or 3 weeks ago, I sent out a survey to the collaborative, and it was really just to kind of get some guidance for the subcommittees on what we should focus on, and also looking ahead and thinking about what we want to do and try to accomplish in the next year. So we're coming to the end of 2019, even though I can't believe it, and 2020 is upon us. So it does delay, doesn't it? Oh yeah. So today we've got quite a few decisions to go through. We've already done the NLC, thank goodness. And now we're going to go through the 4 goals, which are each goal is aligned to a specific clause in our charter, and also try to sort of help the subcommittees focus on exactly what products we think would be the most useful for them to focus on. We already did this. So just a quick overview of the results. There are only 8 responses. So with all the options that are listed today for all of the charter clauses, I want you to keep in mind that these were just suggestions from the other collaborative members. And if there's something that we think would be better, would better meet the needs of what we'd like to focus on in the next year, please feel free to recommend them. Also, for everyone on the Zoom call, I sent out the sort of voting summary, and everyone in the room should have sort of a quick summary of what the slides are going to be presented to you shortly. So this is a general sort of just trying to get a sense of what people wanted to focus on in 2020. The most vocal and I would say the most popular is definitely trying to figure out payment models and financial sustainability for telehealth programs. The second most common idea that was voiced is just identifying barriers. Specifically, people mentioned expanding the scope of our discussions to include all medical services and not just MDs or direct providers, but also identify gaps in services. And then Two other ideas that were thrown in there were engaging and educating stakeholders in telehealth, because we are a policy forum, and also focusing on licensure compacts. So my idea is that for every goal that we vote on today, they're not currently written in the SMART format, meaning specific, measurable, achievable, what's the third one? Something else and time bound, but realistic. But my idea is that what we'll vote on today is just get a sense, and then I'll take a whack at trying to write them in the SMART format. I don't think we have to worry about time bound because these are 2020 goals, but everything else, and I'll send them out to the voting members and then get your feedback and have them be finalized after 14 days or 2 weeks. Does that sound like a reasonable way forward for everyone? Yeah? Okay, great. Okay, so the first one is, the first charter clause that we have is improving access to telehealth education and resources for both patients and providers. And the suggestions that came in were explore sources of funding for increased broadband access, develop a robust FAQ and/or research page for providers and patients on the website with links to education materials and resources. This came up a couple of times. The website is actually heavily featured in all of our goals and things that we want to focus on in the next year. With this one, there's also a couple of people that suggested having a tool for helping patients navigate telehealth payments on there as well, so we can see if we want to throw that in. And then provide updated links to educational conferences and materials on website, or provide additional tools and resources for provider telehealth education. So C is more focused, I guess, just generally, and D is specifically highlighted providers. So John, I'll let you take it away on discussion.
So Ryan, did you want us the collaborative vote on one of those, A through D? Is that the...
Yes. Okay. So, or if you have an idea that you're like, these aren't good ideas, my idea is best, please suggest whatever you think would be better.
So maybe for the folks in the room, we'll have you circle your choice. So this is number 1. And then there's a little spot E for other. Mm-hmm. And for the folks who are on the line, what do we want to do? Do you want to do?
For the folks that are on the line, I guess feel free to send me a message or an email. We can also
just have this.
Yeah, I sent it out to them. So if it's easier for the folks on the line, I sent it out over the Zoom message, but I can also send it out right after this meeting, and you can tell me what you'd prefer.
Yeah, so maybe you just like put a check mark next to, for example, A, or if you want to do E, and then I can send that Word document back to Nicole and myself. Yeah.
Do you think I don't know, do you want to try and discuss them, the pros and cons, or do you want to just vote like that?
Well, I think we'll move on to the next question, because I think this is pretty straightforward. And I just want to say something about FAQs. So we did develop FAQs. One of our first tasks was we developed an FAQ for patients and for providers. Maybe it needs to be refreshed, or maybe we need to somehow update it, feature it in a different place. So just wanted to call that out.
Yeah.
Right, let's go to the number 2.
So number 2 from our charter is enhance the adoption of evidence-based telehealth through a positive patient and provider experience, a reliable technology with interoperability. Oh my gosh. So this one's kind of long. Create a catalog of resources, articles, etc. that provide evidence-based support for the use of telemedicine in different areas of medical specialization. Also develop robust FAQ and/or resource page for providers and patients on website with links to education materials and resources. So fairly similar to what we saw in the previous questions. So like I said, there's a lot of overlap with the ideas that came through. Letter B is develop minimum technology requirement standards. C C is identify 1 or 2 questions regarding patient or provider experience with telemedicine that all members could include in their evaluation surveys so that information can be aggregated across systems. And D is conduct a needs assessment via patient and provider survey to better understand knowledge and skill gaps.
I just want to call out the survey that Brody had sent out to patients earlier. I thought that was really helpful.
I thought so too. So feel free to vote. And once again, for those on the line, feel free to shoot me an email or you can send over the document that I shared on Zoom.
Should we go to the third one?
Sure. Okay. Third is develop recommendations on improving reimbursement and access to services, including origination site restrictions, provider-to-provider consultative models, and technologies and models of care not currently reimbursed. So the options that came through were develop a position regarding payment parity to recommend to legislature, develop a guide to telehealth reimbursement and sustainability to place on the website. There's a delay. Identify gaps in current reimbursement policies and prioritize accordingly. And create evidence table with current literature and data proving effectiveness, efficiency, and the financial feasibility of telehealth services to circulate to agencies and policymakers.
I just want to call out that the ATA has a fair amount of guidelines, and they also have kind of a nice bibliography of studies, and that's grouped by disease area. So that just know that that's out there too.
Right. We could always put a link to that. On
the problem with the ATA is that unless you're a member, you can't access it.
Oh, really?
Yeah. So
super locked down.
It's which is a real shame.
Mm.
And the membership is really high.
And the membership is.
It's not just sort of. Yeah. There's one membership, no Allied Health or Student Rate or.
No. Move on to the next one.
Okay, so this is the last one. Identify the existence of guidelines, clinical documentation, and billing requirements, liability and fraud prevention developed by recognized medical and telemedicine organizations. So the options that came through were develop recommendations for or against use of specific telemedicine consent for care, recommended language regarding provider documentation. Develop a web page at the collaborative website that bundles all of the free resources necessary and possible for patients and providers. Create a template of documentation and billing requirements for telehealth operation and appropriate billing. Or finally, create a catalog of guidelines from each commercial and government payer in Washington that identifies billing guidelines, documentation requirements, and coverage rules for telemedicine services. Then develop recommendations for or against use of specific telemedicine consent for care and recommended language regarding provider documentation. It's a heavy lift, that last one.
It's a lot of website.
It's a lot of website stuff. Which is great, but I ask everyone remember the realistic part of the SMART goal. Okay.
Yeah. So before we do that, I just want to maybe update people on where we are with the website. So as you may recall, previous meetings that Nicole had looked at, maybe moving the hosting away from Wisha, because it's nice and it's free and they're doing it for us, but it's kind of buried.
Yeah.
And so Nicole's mocked up some web pages, and we're just really looking at the cost of it, how much it would cost, and then also where it would be housed, like which servers, and so it would be presumably on the UW servers. And there's a little bit of privacy.
So we're sort of still like ironing that out. But I think one option that may present itself is we may be able to host things on the Wisha website anyway, and just like link to them. So I just have to continue cooperating with them and see if that's a feasible option. If so, then we should be good.
It should be separate from Wisha, but it'd be on their server.
It would be on their server, yeah.
Okay.
Yeah. So that's one option. Yeah.
Just curious if you guys are looking at the Healthier Washington portal. Might want to take a look at that. It is managed by UW, by Ian Bennett. But we've been looking into.
Say more what the Healthier Washington
collaboration portal. It was created by the legislature several years ago when Healthier Washington started to, I think in theory, be the online location for transformation efforts.
Is that part of the 1115 labor stuff?
Yeah, it's associated. I don't know if it's
ACHs and all that. Okay.
Yeah,
right.
There's some ACHs on that, but that.
Words on.
Yeah, totally.
Great, thank you. That's a good idea.
Thank you. Okay, so now we're just going to briefly go over the research subcommittees and try to get some guidance on what products we think they should focus on next. So for the research subcommittee, in the survey, the overwhelming, or the majority, the actual clean-cut majority, was just to better understand the state of telehealth in Washington State. And so that was the survey result. Does anybody disagree with that's the direction that the subcommittee should move in? Does anybody think that that's not what they should do? Oh, going once, going twice. Okay, wonderful. Oh, there's a question that came through on Zoom. I don't know who it's from, but how can we develop telehealth modules of care that can help close the gap with completion quality clinical care metrics, and what are the main drivers in most organizations?
We're talking about metrics.
Yeah.
Does anyone want to elaborate on that? Whoever typed that comment.
Oh, it's from, it might be Dr. Jimenez.
It was from Ricardo. Was that you? All right. Maybe he's doesn't have audio.
Oh, yeah, maybe not. Okay.
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 I feel like the first one, doing the evidence-based policies, that's a lot of work.
Yeah.
As someone who sits on a national guideline committee, it's a ton of work. So there might be something that's more appropriate for a national body or something like that, or the TRC, and our TRC as well.
And the second one, the ATA did not too long ago with 50 state gaps analysis.
Oh.
High level anyway.
Okay.
Jenny, would you mind sending a link to that? That'd be great.
If I can send the link, yeah.
Okay. I mean, that's a great place to start. Yeah.
It's too bad that they're behind a paywall. It sounds like they have really good resources.
Yeah.
Okay. So with this in mind, if we do just try to kind of get a sense, as the research committee, get a sense of the gaps in Washington State, like what's happening, like who's doing what are the gaps, what are we not doing? So I kind of made this little slide to just kind of summarize what we could do. And these are just ideas and some of the shortcomings of whatever direction we decide to go in. So if we do a landscape survey, and or a gap analysis, and we kind of survey all the health systems, and we need to think about, like, who are we making this for? What are we making? Who are we making this for? And also, what's the feasibility of it being a living document, or should we just aim to do a snapshot? The other sort of option that was discussed is doing a data analysis of telehealth claims. So several times the all-payer claims database has been mentioned to identify common telehealth use cases. Once again, we'd have to identify who is this product for. And with this one, there is some hesitancy in the group just because there is a risk of incomplete data. You need specialized data analysis skills in order to do it, and so the actual impact of that product might not be as useful as we would have hoped. So there's other things we could have done as well, but those were kind of the two that consistently floated to the top in our discussions.
And I think that, the telehealth claims, again, that's a huge data set
Right.
that needs to be cleaned up. Maybe it's the next PhD student, Ryan.
I mean, that's not a bad way to go. Have a willing, able-bodied person who you don't have to probably pay any. I would mention for the all-payer claims, I'm not sure about Washington State, but I do believe that self-insured employers are not required to submit to those. So just a potential gap that you might want to check in on.
Gotcha. Thank you. So the question we're posing to the collaborative, or that the research committee is posing to the collaborative, is how should the subcommittee proceed to understand the state of telehealth in Washington State? Do we want to do a landscape survey and kind of get a sense of who and what are currently offering telehealth in the state? Do we want to focus more on what the opportunities are and do an opportunity analysis and identify what's missing in services? Or do we want to tackle the telehealth claims database and do a data analysis there? Should we do a vocal vote?
I think it's best if people can just fill this out
Just keep
and get in
filling
the
it out.
room.
Okay, great.
And then people who are online, they can.
Okay, wonderful.
Is that okay?
Yeah.
That's fine. I was just asking about sounding too simplistic.
Yeah.
This is really very much very high level. Not once did we talk about the consumer. What does the consumer want in this model? Because we can do all this all day, but if we aren't answering the problems and the challenges from a consumer's aspect, it's a so what? It's a nice exercise.
Yeah. Yeah.
And I wrote it down on here, but I think that part is lacking.
Okay. Is that maybe something, do you see that as an issue that the research subcommittee should focus on, or I'm wondering if that would be more of a patient education focus, but maybe not. I mean, that's about educating
I think that
might not be
as all these
answering
things
questions.
move ahead, there needs to be some consumer input.
So Brody DeChinko did some survey. Brody, are you still on the phone?
Yeah, go ahead. Brody, we were just talking about the survey that you did and presented last time. What was your question, Joelle?
Yeah, well, Representative Schmick was just inquiring about what we know from consumers, and you and your colleagues conducted that great survey with the data that you provided us this summer or early fall. So just in follow-up, that consumer information in terms of utilization and interests and gaps, can you recap on that? And areas that we might want to sort of shore up in terms of priorities for the research committee?
Yeah, so we reviewed that last week, and sorry, I had 2 unmute buttons I needed to push. It's pretty secure, this Zoom session. But what we reviewed last time was the reasons why people liked telehealth and the reasons why people were hesitant to use it, and the real purpose there was to determine whether there was certain things that needed to be emphasized in the way that things were explained to consumers, or if there were changes to the product design to try to eliminate barriers for why people would abandon or drop off in the process. And so we didn't make any conclusions on what should be done to improve communications or improve the product, but we did highlight some of the areas that needed to be addressed. And so one of the actions for us was we had free-form text results, and we're still in the process of completing the sentiment analysis. I mean, that's taking a lot longer than just to count up like how people voted on certain things. But as far as like taking free-form text and trying to, get some learnings from that, that's taking a little bit longer. But yeah, we're definitely committed to continuing looking into that. And so it's taking longer than expected.
So I guess considering the connectivity between our research committee and the work they're doing, is that in parallel to what Brody and his colleagues are doing, or does there need to be some sort of continuation or intersection?
I would say there should be. I mean, we should go back and look at that survey. The research committee should look at that and see what's the research that needs to be done. Dig into that a little bit more.
Do you have other questions to add that you think need to be delved into in terms of the consumers that Brody didn't mention?
A couple things to remind. I live in a very rural area, and an awful lot of this stuff is based on broadband. I mean, there's a lot of areas that there is no cell service. I mean, I still have people in my district on dial-up. You remember dial-up? but the technology gap is real, and especially when you get outside of corridors.
Yeah, I remember Jeff said that.
Yeah. And so I get it. It was like the meeting last week about mental health. You know, everybody assumes everybody's got broadband. No, not quite. And but the technology, there is gaps there, and it just kind of keep that in mind.
Are you suggesting that we research those gaps and come up with recommendations for solutions, or I'm trying to tie it back to the research committee?
I understand. I get that. I think that's a bigger apple than we can bite. Honestly.
But your point is well taken. Those are the people who need the care the most, right?
Well, the rural areas are usually poor and sicker. That's pretty. So how is this going to help them in those areas?
We've got a suggestion from Ray Hanley at LDI. What is the evidentiary basis for use of home as origination site for a patient? Is the site more or less effective for specific treatment or conditions? I believe that we brought that up when LDI was here in their presentation, I think. Or sorry, not LDI, LNI.
So I just want to make sure everyone heard what Ray's question was what's the evidence around home as originating site? I mean, are you guys familiar with?
Is this a misinterpretation of the term home that we identified as a collaborative?
No, I think he's just wondering, like,
as I recall, it was an origination site, whether it wasn't a doctor's office or was somebody at home.
And just to put a little meat on the argument is that, well, you don't have vital signs. You don't have objective vital signs if you're coming from home. You know really what's going on. And I think, Ray, the reason...
You're absolutely right. That's exactly what I'm talking about. We misused the term proxies last time. I realize there's a more modern term for who might be with the patient at the time at home. I can't remember what you called it. Telehealth or something. Anyways, as we move through this stuff, we're trying to decide when home is an appropriate site, particularly in this case for injured workers, and what a home actually means, and how well different types of procedures can actually be performed in that sort of a situation. So those are the critical questions to us. And then I also wanted to say that the infrastructure issues are also, when we're dealing with injured workers across the entire state, the representative is right. Many times they don't have any fast speed hookup, and we also need visuals as well. So we're interested in home as an origination site, which is we get a lot of push for, and we're also very interested in finding out a little bit more about should I call it the clinical focus of the types of visits that would be appropriate.
Okay. So I want to be sensitive to time. Wondering if we could maybe table this payment model. We can at least have people look at it, look at the slides, and then you can see that the most important question for folks who responded was gathering information about current payer payment models. And I just want to call out both Premier and Regents that they have links and they update those annually, if not more frequently. And I think that's an example of kind of up-to-date, really easy to access information. I wish all the payers were like that. So that'd be my 2 cents on how to get that information out.
The decision for the collaborative from the payment model subcommittee is mostly, okay, if we want to focus on, getting the policies into one place, do we want like a matrix that we have posted somewhere? Once again, how often should it be updated? Do we want a snapshot or do we want a living document? Or, do we think that it would be more useful to have a comparative analysis that we write, in this case, probably directed towards, healthcare systems that are trying to figure out who covers what in Washington State. And then I think that's it.
Okay, so we're gonna next, if you guys could look at the one pager, feel free to write in comments. If you're on Zoom, if you can just download that Word document and type your responses, send it back to Nicole and myself.
Yes. And for those on the phone, I'll send out an email like right now to everybody.
And Nicole?
Yes.
And Representative Riccelli, I can change the abstain vote to a support vote on the nursing compact.
Okay.
Awesome.
Thanks, Denny. You saved a meeting for Representative Riccelli. Good, so this is our public comment period. There are folks who are not in the collaborative who wanted to say hi or suggest we talk about things at future meetings. This is a great time to speak up. I do want to just make a plug that our next meeting, we're going to talk about something that's not traditionally medicine, it's optometry. So a couple of times ago, we had folks from the Optometry Association come, and I think it was in Wenatchee, and we will have a formal presentation from them, as well as our chair of ophthalmology here at the UW. So just wanted to highlight that that's coming our way next time.
And the next meeting will be in the either it's like January 20th to 24th, somewhere in there. We're still ironing out the exact date.
And location too.
Oh yes, and location too. If anybody wants to volunteer, let me know.
Yeah.
To host.
I think the Renton and South Sound areas work really well for a lot of people. Folks in Seattle, it's not too far. I know that for a lot of the legislators, it's a shorter drive. It's still
if it's in the afternoon, it actually builds. Otherwise, it's kind of hard. No. Friday afternoon. Not my favorite time, but.
Sorry, y'all.
I have a comment.
Yeah, go ahead.
I missed the last meeting where you guys, I guess, went over the consumer research, but I think I would be interested in that, and I think a lot of that informs the the patient education piece of that, and just understanding where there are resources and not assuming that people have access to telemedicine, because there is a desire to get telemedicine out to rural locations, but if they are on dial-up, then there's that kind of disconnect. So just gathering that information, it is a heavy lift, but I think it's important.
Okay. Thank you. Folks on the line, Nancy Lawton, you were on. Christy.
Zoom's quiet.
Okay, well, great. I think we're right at 3 o'clock, so thanks everyone.
Thank you, everyone.
And we'll look forward to hearing some responses, and we'll get back to the next meeting time, sometime in that third week of January. South Sound region. Thanks everyone.
Thank you.
Thank you.
Thank you.